Kim Morley, and it's back to thinking about women with epilepsy, but from the perspective of a midwife and nurse. Kim Morley, please.
Thank you, and good afternoon to you all, and thank you for asking me to be a speaker. I'm quite unique. I'm a practitioner specialising in the management of anti-epileptic drugs as a midwife. And I have mixed views about valproate due to the potential devastating harm caused by pregnancy exposure versus lives disrupted and sometimes lost because of women not taking their anti-epileptic drugs or other anti-epileptic drugs not controlling their seizures. I set up a unique specialist service 17 years ago to be a voice for women with epilepsy and to raise professional and public awareness about the potential teratogenic risk of drugs like sodium valproate. By effectively linking with other healthcare professionals, and that is key, I have ensured women are correctly diagnosed with epilepsy and taking an anti-epileptic drug regime that carries the least risk of harming their baby whilst protecting them from uncontrolled seizures. Now, for the majority of women, this holistic approach starts long before pregnancy is considered. Women are fully informed of potential risks from the available research evidence and empowered with their decision-making in preparation of motherhood. Evidence demonstrates that women receiving this type of support are more likely to have healthy pregnancies and less likely to have adverse outcomes, and that's certainly been my experience. It upsets me greatly when women become pregnant, never having received that type of care. With modern communication, that's totally unacceptable. Furthermore, if disclosure about risk is not handled by a knowledgeable practitioner, the consequences can be profound. This is because women instinctively put their baby's well-being before their own, and this can lead to a sudden discontinuance of anti-epileptic drugs. And very sadly, as identified in the maternal mortality reports, this can result in some pregnant women never getting to see their babies because they've died as a result of their epilepsy. I have witnessed the profound effects of sodium valproate syndrome on childhood development and behaviour, and the challenges women face trying to obtain a diagnosis. This can deny children of appropriate proactive specialist support and impact further on their potential development. One woman was referred to me from another NHS trust to gain support for her child who has severe valproate syndrome. She said even though my ambition was to prevent this syndrome, she would never have tried an alternative anti-epileptic drug or a lower dose of valproate. The risks were too great. But she did want to be a mum. She was so grateful that I'd been the first person to offer her support. No one would acknowledge that valproate caused her child harm. I've developed deep understanding of why women choose to stay on valproate, as well as having to refrain from driving and the subsequent impact on quality of life. Changing anti-epileptic drugs can result in complete loss of seizure control, serious adverse effects, and very sadly, in some cases, an increased risk of death. Motherhood itself raises a further dilemma for women if they're taking a drug like valproate, because the consequences of a change of drug at this stage and a loss of seizure control could compromise their ability to parent safely. Seeing children with valproate abnormalities, including metopic craniosynostosis, is where the skull bones fuse prematurely, is extremely worrying. This condition in milder forms can go undetected, but still seriously impact on neurodevelopment. How can we possibly know the extent of the adverse effects caused by valproate unless every child exposed to the drug in utero receives expert assessment and childhood follow-up? This should be mandatory, and there should also be a mandatory register of all pregnancies, even those which have sadly miscarried, exposed to valproate. And in answer to question 2, my views about how to reduce the risk, as one consequence of the measures in place, there are now some young women with generalised epilepsy coming through transition whose lives have been disrupted by the cocktail of other anti-epileptic drugs they've been prescribed without achieving seizure control. Invariably, valproate's never been mentioned as an alternative because of the potential risk in pregnancy, yet it may be the only drug that will provide seizure control, as we heard today. One case, a young girl was being homeschooled as she was having clusters of uncontrolled convulsive seizures, problems with word finding, which can be a side effect of the drug, and angry outbursts. Her cognitive skills were reduced and she was at increased risk of sudden unexpected death in epilepsy. Following our joint specialist support, her 4 anti-epileptic drugs were gradually withdrawn and substituted for a low dose of valproate. An effective contraceptive device, obviously that's key, is in place, and this young woman returned to school, then college, and is at university seizure-free. She has a boyfriend, she phones me regularly, she's fully informed of possible adverse effects of valproate and the consequences of exposure in future pregnancy, but she wants to achieve her goals before considering any changes, and we will continue to support her on that journey to motherhood. The measures in place will continue to fall short because of the lack of expertise in supporting women with epilepsy with prescribing decisions. Anti-epileptic drugs are the most complex drugs to prescribe in the formulary. Incorrect management can result in morbidity and mortality. Epilepsy services in the UK are fragmented due to lack of neurologists specialising in epilepsy, shortage of epilepsy specialist nurses, paucity of GPs with a specialist interest in epilepsy, and lack of knowledge about epilepsy and the management of anti-epileptic drugs in maternity services. For the purpose of reducing this disparity, I provide expert advice to professional and charitable groups and have developed my own website, womenwithepilepsy.co.uk, which showcases resources and information as a strategy to increase knowledge about risk assessment and reduction, and this is being used worldwide. So what other measures should be taken to reduce the risk of valproate during pregnancy? Well, the thousands of voices represented by the speakers today, the voices of thousands of women and families represented by the speakers today are proof that more needs to be done to reduce the risk of valproate during pregnancy. It is imperative that women taking anti-epileptic drugs for any condition should receive a continuum of expert support to inform their decision-making. As there is a shortage of professionals specialising in the management of anti-epileptic drugs, an expert European panel should be formed, or is being formed, to guide professionals how to manage anti-epileptic drugs in women of childbearing potential, and I would be happy to be part of that panel. I was so pleased about the pharmacists bringing up about their role, because my last paragraph finishes with them. Pharmacists have an expert pharmaceutical knowledge and are in an optimal position to help increase knowledge about valproate risks. Providing additional training and funding for this group of professionals would be optimal in order they are all experts in anti-epileptic drug medicines management and pharmacovigilance. Each time a woman of childbearing potential collects her prescription, there should be an additional check as to whether she's received the patient valproate guide and had the opportunity of a medication review, of which they're brilliant, and when you have a partnership with the pharmacist, it really is optimal care. Pharmacists should be encouraged to refer all women of childbearing potential taking valproate for preconception, specialist support, and provide information resources in appropriate format about contraception, folic acid, risk assessment, and medicines management. Thank you.
Well, thank you very much, Ms.